This computer. Okay, here we go. Give them a second to join. Okay. I think we're good to go.
Okay. Good. All right. So I want to take a minute to introduce our speaker today. First of all, I really want to thank everybody for coming to these webinars. It's a very important tool for CLEAR to be able to stay in touch with our membership and to continue to educate the membership. There's so many things that are related etiologically to the development of scoliosis. I know that Dr. Moda and I are now taking this training. For me, it's the second time with the Isico people in Italy. But one thing they do not talk about is the subject that we're going to talk about today, which is the relationship of sleep position to the development of adolescent idiopathic scoliosis. It's a really groundbreaking topic. Like when I heard about it and I was reading Dr. Grunstein's article, I felt like, yeah, like it makes so much sense, but it never occurred to me. I'm very curious, actually. Hopefully, he'll mention how he arrived even at the idea to investigate this. But here we have a chiropractor. It's already unusual in the world of research. We don't have so many chiropractors doing original research. They're mainly doing case studies. So we have a chiropractor. We have a guy who's written at least two articles that I know of, and I'm hoping that he's going to discuss a little bit of the second article, which is about sleep position and lower back pain. He also has made a connection with Dr. Grievous, who's one of the real heavyweights in the scoliosis research world. So just the fact that Grievous put his name on the article and was co-author speaks volumes to the legitimacy of the theory. Without any further ado, I want to introduce Dr. Jarrett and go ahead. What we're going to do is we're going to have anybody who has any questions put them into the chat box in the Zoom, and Dr. Jarrett will either respond to them during his talk, or we're going to end, like, say, 5 or 10 minutes before the end of the hour, and people will have an opportunity to get their questions answered at that time. So you'll be muted, but you can put your questions into the chat. Okay, Dr. Jarrett, please go ahead. Thank you very much.
All right, thanks, Dr. Andrew. Yes, Dr. Jarrett Grunstein. I graduated from Palmer West just over 20 years ago and have been in practice for 20 years. My story is a little strange how I came to this, actually. When I first opened my practice in Clearwater, Florida, I included on my history form, how do you sleep? Your back, your side, your stomach. And that started an inquiry that led me down this road. I started thinking about sleeping pillows and other orthotics because I realized that most people shift between their side and their back, and there wasn't really a sleeping pillow per se on that for that particular type of sleeping pattern. And eventually I started looking at knee pillows for side sleeping particularly. And this was about 2018. And what happened basically is I had an aha moment that this is what's causing the lumbar spine to curve in children. Now, the strange thing about this is that I hadn't thought about scoliosis in about 15 years prior to that, since I was in school. I never really treat scoliosis. I treat the pain associated with it. But I did arrive at this from a very unusual angle. So basically what happened is I spent the next 4 or 5 years writing a paper. The paper, hopefully some of you had a chance to look at it. It's entitled "The Etiology of Adolescent Idiopathic Scoliosis is Sleep Position the Missing Link, the Nighttime Perfect Storm Hypothesis." And Dr. Grivas, he got involved with this because, well, he was the primary author in well over 12 of the studies I had in the paper. And one of the studies I didn't really understand. There was a question I had, and I emailed him because I couldn't figure it out. And he emailed me back within an hour saying, I found a mistake in the study. And it was going off to the publisher, so he couldn't change it. But he was pleased that I had found the mistake. And then I asked him to read the paper when I finished it 8 months later, and he did. And he felt like there was some legitimacy to it and was willing to be a co-author. And we'd worked on a number of things since. So really my interest is in sleep position, and that took me to the adolescent idiopathic scoliosis world. Basically, my work finally got published. It was published in 23 in the International Journal of Advanced Research, and I was privileged in 2022 to go to SOSORT and present it in San Sebastian, Spain. And so the basis of the hypothesis is that there's a perfect storm that occurs, and it includes four components. One is genetics that we know of. Two is the adolescent growth spurt. Three is what I call the provocative sleep position, and there's two of those that we'll run through. And four is very specific around REM sleep. And REM sleep, as I'll discuss later, is a critical component of the entire story. So the interesting thing to talk about at the beginning of this is, why has it been assumed within the scoliosis community that sleep position isn't involved with the curvature? And that goes back to 1948. Dr. Cobb, the Cobb angle, did a study where he kept over 30 children with growing curves in bed for 22 hours a day for 3 months. And what he discovered is, in that all but one of the children, the curve had completely stopped. And the conclusion from that was that since if you keep kids in bed all day long, 22 hours a day, then the curve stops, then it must be happening when the individual is upright. That's when it's occurring. This was cited a year later by Alvin Arkin in 1949 in a paper. And then fast forward 43 years later, Dr. Burwell, in a paper called The Pathogenesis of Idiopathic Scoliosis, the Nottingham concept referred back to the Arkin paper in 49. So it was basically just assumed that scoliosis is something that happens when you're upright, and that sleep position just wasn't a major player. Now, the irony in all of this is that the person who initially discovered scoliosis and wrote about it was Hippocrates 2,400 years ago. And what did Hippocrates have to say about scoliosis? What he thought caused it? He thought it had to do with how the children were sleeping at night. So we're basically doing a full circle 2,500 years later. So basically, in terms of scoliosis, obviously it's idiopathic, so we don't know what causes it. But what do we know? We know that they've evaluated, there's been many, many studies on the neurology, the hormones, the muscles, and the bones. And what's been basically concluded is that these are all secondary downstream effects of scoliosis and not the causative factor. What also do we know about? We know about the genetics, which we're going to go into in detail. And yet genetics, despite the association studies, linkage studies, evaluation of candidate genes, none of these have proven to be the ultimate cause. And the reason that we know it's not purely genetic, and that in fact it's an epigenetic disease, is that basically there's been twin studies done. And concordant studies with monozygotic twins who have identical genes, what they've found is that there's a 73% concordance rate, which means that 100 out of 100 kids who are twins, if it's purely genetic, they should have the identical curve, the identical degree of curvature, and the location of the curvature. And that's just not how this is played out. Growers et al. Looked at 64,578 twins in the Swedish twin registry. And what he concluded after all of that research is that 38% of the chance of developing AIS was genetic, and 62% had to do with the environmental factors. So basically, by 2005, Dr. Burwell published a different study, basically concluding that this is indeed an epigenetic disease. So, what's going on in the environment? This has been researched quite a bit. They've looked at lifestyle factors, they've looked at dietary factors, environmental factors such as industrialization, they've looked at different exercises. None of this is shown to be the actual causative agent. Vitamin D looked promising for a while, but then Keebzag in 2019 found that kids with and without AIS had the same vitamin D levels. So that was basically ruled out. Chlorinated pools is another possibility. They did find some correlation there. Outside of that, the only study I was able to find that showed some meaningful relationship in the environment was a study done by Baroni et al. Down in Brazil, and it was a hammock study. What they did was they had around 200 children, half of whom didn't have scoliosis, half did, and they looked at all the factors, their lifestyle habits, sexual maturation, ergonomics of their desks. They looked at everything, and the only thing they found was an inverse relationship between the ones who slept in hammocks more had less incidence or degree of scoliosis. And that's significant because how do you sleep in this hammock? You generally sleep on your back. All right. And let me just go back because I realized I didn't really actually complete the story about Dr. Cobb. When I was about to publish the paper and asked Dr. Grivas if he would be a co-author, he asked me one question and he said, based upon this question, I will give you my co-authorship or not. He said, Dr. Cobb kept them in bed and the curve stopped. How do you explain that? Your hypothesis is stating exactly the opposite. And so what I realized is that in essence, it was a riddle, because try keeping an 11-year-old, 12-year-old in bed for 22 hours a day. It's very difficult. So during that time period, when ethics were a little different from now, they were actually allowed to restrain children in bed. And that's how they kept them in bed for 22 hours a day. And what position was considered most neutral for the spine? On their back. So in essence, what he did was he kept these 30 or so children out of these two, what I call provocative sleep positions. And what happened? The curve stopped. So when I explained this to Dr. Grivas, he agreed that this is possibly how they essentially arrived at the wrong conclusion from a study that they've been referring back to for close to 70 years. So once again, the four components of the hypothesis are genetics, growth spurt, the provocative sleep positions during REM sleep. And this is layered upon Punjabi's spinal stabilization model. If you're familiar with that, there's three components to his model. You have the passive subsystem, the active subsystem, and the neural control subsystem. And the three of these work together to stabilize the spine. And so a stable spine can withstand varying degrees of mechanical demands due to changes in spinal posture and also adapt to static and dynamic loads. However, if one of these three subsystems goes down over time, ultimately stabilization is going to be lost. In this perfect storm hypothesis, all three systems are down at the same time. And that's why I believe that this is the most vulnerable window for these children. And we're going to go through this one by one. So the active subsystem is comprised of the muscles and tendons that generate stabilizing forces. The passive subsystem are the vertebra, the discs, the facet joints, and the ligaments. And the neural control subsystem are the sensors or mechanoreceptors and the central nervous system, the brain and the spinal cord. And these monitor the motion and activate muscles accordingly to stabilize the spine. So essentially, let's talk about factor number one in the hypothesis, and that is genetics. And the genetics, what we know, and what I'm going to go through, is directly affecting this passive subsystem of the vertebra, the discs, the facet joints, and the ligaments. What we know about bone and genetics with kids with AIS, they have a low bone mineral density. Many researchers have suggested this is an independent risk factor associated with AIS. Genetic mutations associated with the metabolism of bone include OPG, RUNXT2, MAPK7, and others. There's epigenetic abnormalities in the bone, MIR145, beta-catenin. There's hormonal elements that they've found that are also interfering with bone metabolism. These include leptin signaling pathways, melatonin signaling, estrogen involvement. Okay, so we know the bones, there's a problem there. Now we go to the intervertebral discs. They found genetic mutations associated with the discs and their development, the COMP gene, the MMP3, the IL-6, type X collagen gene. All of these disrupt the normal development of the discs in these children with AIS. Apparently, the disc displayed at least 3 times more deformation in the true sagittal, transverse, and coronal planes as compared to the deformation of the vertebra. So the discs play a huge role in the curvature. And when they've analyzed the histology, they found decreased proliferative cell activity and increased protein synthesis. So that's the discs. Next, we have the facets. There's studies where the analysis of the microarchitecture of the vertebral facets in the thoracic spine found that the facets on the convex side were more porous and had a thinner cortex as compared to the concave side. And finally, ligaments. The ligaments found in kids with AIS, particularly the FBN1 gene, is significantly associated with AIS susceptibility, and this gene is critical in the development of ligaments. And in addition, Newman et al. Showed that low bone mineral density may negatively affect the structural integrity of the spinal ligaments. So within the context of Punjabi's model, the passive subsystem is seriously compromised in these children. So the next is the active subsystem and the neural control subsystem. And REM sleep basically is going to address both of these. Essentially, let's see. So basically, there's a lot of studies of researchers looking to see if children with AIS have some type of neurological defect that can explain exactly what's happening. And what they've discovered, and most of them have concluded that once again, the defects that they have found, they're secondary responses to the scoliotic curve. In other words, they don't actually have neurological defects that are primarily causing this. So let's talk about REM sleep a little bit. REM sleep is associated with desynchronization on the EEG. There's hippocampal theta activity, but most germane to this topic is that there's a loss of postural muscle tone. So essentially, during REM sleep, from the neck down, we are essentially paralyzed. And REM sleep comes around about 5 times during the course of the night. It starts out about 10, 15 minutes long, and then it just gets progressively longer throughout the night. The last episode of REM sleep could be 50 or 60 minutes, where this child is in a sleep position, and the muscles that are supposed to be stabilizing the spine are completely down for the count. So REM sleep is a critical part of the model. So basically, the time in the sleep position matters most during REM sleep. The more time the sleep position during REM sleep, when the muscles are down for the count, there's going to be more susceptibility. So let's talk about other studies that have been done that through one lens, they're looking at one thing, and I'm going to put a different lens on it through the hypothesis that I created. So for example, kids with AIS have found to have lower levels of leptin. Now, what they didn't talk about is that leptin links with REM sleep. Lower REM sleep is accompanied by leptin suppression, so that REM heavy sleepers may show chronically low leptin levels. And once again, the more REM sleep, the more you're in the sleep position that's doing the damage potentially. Another one is BMI. We know that these children who have this condition notoriously have low BMI. Low BMI is also linked to longer, quieter sleep. So more sleep may mean more REM exposure, and that once again is a vulnerability. And finally, studies have been done, particularly by my co-author, Dr. Grivas, about latitude. What they found is that the more northern latitudes progressively cause increased incidence of AIS. The closer you get to the equator, you have less and less incidence. Now, the connection here is that what we also know is that the more northern you get, the longer they will sleep on average. So again, the sleep exposure is connected to another finding, and I'm linking it back to the hypothesis. So let's talk about factor 3 of 4. This is the big topic. So any of you who've talked to your patients about their sleep position probably have discovered some people sleep on their stomach, and you well know that that's not a good thing. And the other major problem sleeping position is sleeping on their side with their legs scissored. And within the context of this model, I call these the provocative sleep positions. There's the prone provocative sleep position, and then there's the lateral provocative sleep position. If you look at the paper, and I'm more than happy to send you the link to it if you haven't seen it, but there's pictures of these two postures. And so let's start with the prone positions. This in particular is connected in this model with the thoracic curvature. So what happens in the prone position is that these children aren't lying flat prone. The reason that they don't is that the lumbar spine would be in a hyperextended position, so the facet joints would jam. And in that position, there would be a maximum amount of cervical rotation, which would be irritating to the facet joints. So what they do, what adults do as well, is they naturally will raise up one leg, typically the right leg, and it's almost like a kickstand. As it raises up, it tilts the thorax at an angle. And so if they raise their right leg up, they're going to be tilting in a way so they're more compressed into the mattress on their left anterior rib cage. And what that does in this model, that anterior left rib cage is meeting pressure back from the mattress, and that starts out a rotational force. And so what I explain in the paper is that that force starts in the left anterior rib cage. It goes around across the sternum to the right anterior rib cage, and then around the back to the posterior ribs, which now are compressing right into the vertebra. So there is a big question here in the research community. The question is, do the vertebra rotate the ribs, or do the ribs rotate the vertebra? Even in the most recent reviews, you will see the conclusion that the vertebra rotate the ribs. Now, I can cite a study, again, by my co-author, who disproved this. And what they did was they had kids come from school screenings, and they used a scoliometer, and they found the kids had rib humping, and then would take x-rays of their spine. And what they found is roughly 17% of the kids who had a rib hump had perfectly straight spines. So if the vertebra were primarily responsible for turning the rib cage, then you would expect 100% of the vertebra to be curved if the rib hump exists, and that wasn't the case. So that actually contradicts that. And even going back earlier to Dr. Rofe in the late 1950s, he pointed out directly from his findings, it's that the ribs are pushing in and rotating the vertebra. And he was even more specific than that. He said that the rib, the way it actually meets on the convex side of the curvature, the vertebra, it's actually at the posterior axis of the vertebra. In other words, as that right rib is coming in, it's hitting more posteriorly and causing the vertebra, therefore, to rotate rightward, which is in a rightward direction, which is exactly what we see in a thoracic curvature. That is a convexity to the right. The vertebrae are also rotated to the right. Let's see, where did I leave off here? Apologize. Okay. So let's talk a little bit about two forces that are actually affecting the spine in this, what I call prone provocative sleep position. You have the rotational force that I just explained, and the other force is a force of extension, basically causing a hypokyphosis, which researchers have discovered is consistent in children with a thoracic scoliosis. So basically what's happening is you have a child who is face down and you have gravity bearing down on their spine throughout the night, slowly taking a thoracic kyphosis and night after night after night, flattening it out. And basically the idea is that that's the one component. The other component is that when they're in that sleeping position, they also have either one or both of their arms above their head, and that also causes extension of the thoracic spine. So there's really two elements that are causing a straightening out of that kyphosis. And so basically what you have is two components, rotation and extension of the thoracic spine from the sleeping position. But the spine won't rotate until there is enough extension in the spine. There has to be that extension there for there to be rotational instability. So the way this plays out is initially you have the ribs pressing in to the vertebra, but since there's still that kyphosis and they can't rotate the vertebra, you're going to start to see the ribs slightly start to hump. And this goes into another finding. They've found that the ribs on the convex side of the curvature tend to be longer than on the concave side. And if you look at beam mechanics, essentially, as that pressing is happening in the ribs, the outer part of the ribs are actually being tensed, being stretched apart, which would cause extra growth. And that would explain why the ribs on the convex side are actually slightly longer. But ultimately what does happen is that hypokyphosis reaches a certain state, and then the ribs can then start rotating the vertebra. Another finding that scientists have made is that there's what they call relative anterior spinal overgrowth. So the anterior aspects of the vertebra are longer, vertically longer, relative to the posterior aspects. And in this model that I'm explaining, if you have something that's being pressed down, and it's the same idea of beam mechanics, the lower part actually would stretch, the upper part would compress, and that stretching on the lower part is consistent with what they call, I can never say his name, Hooter-Volkmann law, which essentially means the growth plates, if they're compressed, it suppresses growth. If they're tensiled, they will increase the growth, which is explained in this model. Okay, so that is the prone provocative sleep position. The lateral provocative sleep position is what I discuss related to the lumbar curvature. And essentially, you have most of the time a left convex curvature. And in this model, the child would be sleeping on their left side, and the upper leg would be folding forward and resting on the mattress. And in that obliquity of the pelvis, what also happens now in the lumbar spine are two things. You're going to have rotation of the lumbar spine, and you're also going to have extension of the lumbar spine. And that extension is very important because in coupling motion in the lumbar spine, if there's extension in the lumbar spine, the coupling motion causes rotation and lateral flexion to be in the same direction. But if there's flexion in the lumbar spine, it's just the opposite. Rotation and lateral flexion go in the opposite direction. So you can picture a child who's on his left side or her left side, and the gravitational force is forcing there to be left lateral flexion. And since it's slightly an extension, you also now have left rotation of the associated vertebra. Again, this matches exactly what the lumbar curvature looks like. Okay, so moving on. The fourth component is the growth spurt. We all know that this is connected to adolescence, and these are when the kids are most vulnerable. The curve initiates and progresses during peaks during early puberty. The spine is biologically most deformable during this rapid growth period. The growth plates are driving the progression, where the vertebral growth plates control longitudinal spinal growth, and they're highly responsive to mechanical loading. So nighttime loading overlaps directly with this growth biology. And so let's talk a little bit about when bones grow. When do they grow? The studies that I've found show that, particularly in animal studies, that 90% of the bone elongation occurs when the animal is resting. I think it was a sheep they used in this particular study, where they took pins and pinned it into the bones, and they were able to monitor every 3 seconds what was occurring in terms of bone growth. So they were able to really tag when the growth was occurring, and it was at night when they were recumbent. And the other aspect of bone growth that we know is that it is on a circadian rhythm. Most nucleated cells in the body have their own particular circadian rhythm, and bone cells are no different. And what we know is that the turnover activity peaks at night, not during the day. So this is another clue that the curvature is happening, and it's happening at night, potentially. So there is one author who wrote a review. It was a very impressive review. And what he stated is that hypothesis that really outlines this, what's causing this, it has to include an explanation why girls have curves that accelerate so much more commonly than boys. So let's discover why girls are potentially so much more susceptible to the acceleration of the curvature. One of the reasons has to do with their puberty. It begins earlier and it lasts longer. So the bone remains deformable for a longer period of time. Another thing is that the anatomy, the gender-specific anatomy, specifically breast development and hip development. So breast development starts in what are called Tanner stages of breast development. Tanner stage 2 is when the breast buds start to develop, and it's a stage when the tissue can be very tender, and especially pressure against a mattress, a child might be inclined to slightly position themselves to get out of that pressure position, which is irritating, and they're possibly going to move slightly in a way that's going to cause more rotational force on the thorax. And in addition, as the breast tissue grows, there's more mass pressing on the anterior rib cage on the left side, once again creating more rotational force, which ultimately means that posterior right rib cage is pressing more into the thoracic vertebra. So that's how breast development may be connected with the prone provocative sleep position. Hip development may be connected to the lateral provocative sleep position. As the hips start to widen at the ages of 9, 10, 11, 12, essentially you have a higher moment arm where there's a greater rotational force being put on the lumbar spine as the hip widens. Okay, so therefore puberty doesn't just change biology. Within this model, it changes nighttime biomechanics. So finally, I haven't discussed the thoracolumbar curve. Um, it may be developed by the lateral provocative sleep position. And this may just be an issue of how much flexion there is in that upper leg. In other words, less flexion would affect the lumbar spine more, and the more flexion there was in that upper leg may actually cause more rotation involved in the T12 to L1 region, the thoracolumbar curve. All right. And finally, I just want to discuss the path forward. Obviously, this is simply a hypothesis, and it requires quite a bit of testing to turn it into what could be a viable theory. And the first thing would be to do some type of questionnaire. The reason that doesn't work is that what we've shown is that self-reporting on sleep position is very unreliable. So that really wouldn't be an accurate way to do it. You could involve the parents, because parents will oftentimes come into their child's bedroom and see the sleep position. When I've done this with children who I treat who come in with scoliosis and I'm just treating their pain, the children will swear to me that they don't sleep on their stomach, and the parent is standing right there saying they sleep on their stomach. So self-reporting isn't really that helpful. So we would probably have to use some type of video technology. I know there's a sensitivity around videotaping children while they're sleeping, but there are home units, particularly Dr. Doug Carey published a report, I believe it was in 2019, where they showed a pretty good system where you could send someone home with a camera and it would videotape them and actually discover how they're sleeping at night. There's also other newer technologies that can measure the pressure on the mattress, and through a combination of these technologies, this can be actually researched to determine whether or not they are actually in these provocative sleep positions, particularly more towards the second half of the night when REM sleep is occurring longer. And if this first stage of the study was actually shown to make this connection, the next step would be to keep the kids out of these two provocative sleep positions, and this would require an orthotic device. I have created a device for this. It's called the Theoja Buddy. Basically, it's a stuffed animal. It's basically a glorified body pillow. The upper part would be a stuffed animal that would attach around their thorax, and the lower part would go between their knees and attach to each of their thighs, so that when they're on their side, they couldn't scissor their legs, and the stuffed animal would just be in the way, so they wouldn't be able to go to their stomachs. And you would conduct a study with 100 kids potentially who had AIS. 50 of them get the device, 50 don't. Ideally, the curve would be between 10 and 25 degrees. And if the curve was halted with the kids using the device, this would potentially prove that the hypothesis has some validity. And then you would do larger and larger studies. I think it's exciting that if this was actually how the curve developed, and you could actually make a device that would cost, I don't know, $50 to make, that you could reach a lot of children around the world who were economically disadvantaged and wouldn't have access to medical care. And in those instances, as we know, a percentage of these children are going to get curves that are 30, 40, 50 degrees. And I think it's over 40 degrees or so. If they go into adulthood, it's every year or so, it's going to go another degree. So this is a huge quality of life killer for many, many children around the world and adults. So basically, that's my entire presentation. I hope it was somewhat interesting. If anyone wants my email and wants to talk about this directly, I'd be more than happy to give that at the end. But for now, I think we have 19 minutes left. So why don't we just open it up to any questions? I guess someone, Dr. Andrew, if you want to kind of mediate that, that would be great.
Okay. First of all, thanks very much. That was very interesting, and it really helped me actually to hear you discussing it, because I've read your paper, I think at least twice, maybe three times, but to hear you talk about it gives a different reality to the whole thing. I actually had a couple of questions, and one is, how does the theory account for the overwhelming majority of thoracic scoliosis being dextro? Wouldn't your theory anticipate that there's more of a 50-50 ratio between dextro and levo scoliosis in the thoracic spine?
So you're saying that the convex curve is mostly to the right.
Yep.
Okay. So actually, this is in the paper. I didn't want to include everything because I thought I was going to run out of time. Now I realize I had plenty of time. What I've noticed, in part, just because I've had more pillow talk with thousands of patients through the years, finding out exactly how they sleep, what it seems is the predominance is when they're raising that leg and creating that kickstand effect. Most people, it's the right leg that they're raising. So the dynamic that I was describing, where they would be on their left anterior chest, creating that right pressure on the right side of the vertebra, that would be how it would play out. So I believe there's a connection between handedness and the proclivity to raise that right leg. What we know is that about 90% of people are right-handed, and I think that has to do with that predominance to lift the right leg and have them face to the right, which would explain why the convexity is to the right so much.
Good, thank you. Dr. Myers is asking, what about lumbar scoliosis, sleeping position that can make it worse? And I believe you did discuss that with the second provocative sleep position. That was really focused more on lumbar spinal development, right?
Yes, the lateral provocative sleep position is distinctly pointing to the fact that if the legs are scissored, it doesn't just cause obliquity in the pelvis, but it also causes lumbar rotation and extension. And then if they're on their side, you're going to have a dipping because of gravity, a lateral flexion towards the mattress. And there's going to be this coupling motion. And since the obliquity of the pelvis causes extension in the lumbar spine, the coupling motion is going to be it's going to be left lateral flexion because they're on their left side going down, and that's going to be coupled with left rotation, which is exactly what we see in the lumbar curve.
I actually had a comment, which is that this is a great justification for putting children into night bracing, because your body pillow is one idea, but another idea is night bracing. And so if we have a mild curve in a growing child that has risk factors, we can place them into corrected posture. They would never get into the provocative sleep position while they're wearing the brace. So that was interesting to me. Dr. Sue's asking, is there a link to your what'd you call it? The job buddy?
The Theoja buddy,
Theoja buddy.
that was named after Dr. Theodoros Grivas, and Ja is Jarrett. So yeah, I'm sorry, what was the question about the device?
Is there a link to
Oh,
purchase that?
no. I did create a prototype. Once I started researching what it would cost to produce this according to FDA standards and this going down this road, it's a very, very expensive endeavor. So I am going to come at this from a different angle. We're actually starting a pillow company within the next 6 months, and that gets into the other area of studies that I'm more than happy to share briefly. You had mentioned it at the beginning. Um, if you want, I can share just 30 seconds about it now. I have come to feel that mostly what I'm treating in my office in terms of back and neck pain, I would say has to do with sleep position. In this paper, I'm outlining how it could potentially cause curvatures, but I think these sleep positions can also cause a lot of back and neck pain for the same reason: REM sleep, the spine's not stabilized, and this is causing, in my view, a lot of problems. So I just finished it's actually a 3-paper series, a foundational paper on a field I call orthosomnology. The European Spine Journal is reviewing it right now. Hopefully it will get published. And then the second paper has to do with the cervical spine. And the third is the lumbopelvic region. So I really think this connection. So hopefully these pillow companies will raise enough money that I can circle back and do the research on the Theoja Buddy.
Excellent. Excellent. Okay. Very good. If anybody has any other questions, put the question to the chat box and then we'll be able to see it because I think everybody's muted. Nope. No other questions. I think that's it. Let me just look again. Oh yeah, here's another question. With adults developing and using the same principles of your theory, while the adult doesn't have the growth spurt, the adult has an additional risk factor, which is the degenerative changes that take place in the spine, which cause laxity in the ligaments. So it's like you're replacing one risk factor with another, and we know that interestingly in de novo adult scoliosis, it is pretty much 50-50 right and left. So maybe in this situation, that's also a factor in the development of de novo scoliosis. I mean, I could logically that makes sense to me. Have you thought about this? Have you considered writing a paper about the adult de novo scoliosis development and its relationship to sleep?
Years ago, I actually was thinking about it, and I think it's a very interesting follow-up that is worthy of investigation. I think I know. I believe you wrote a book on this topic yourself, so you probably have quite a bit of familiarity. I may have to use you as a resource.
Anybody else have any other questions? Come on, people. Dig deep. Nothing? Well, I think we're ending about 10 minutes early.
Okay, I'm going to put my email address in the chat box, so anyone is more than happy. They just want to ask questions may arise later that they didn't think of now. So more than happy to correspond via email, and we can talk about anything you'd like to.
Great. Okay. Well, again, I really want to thank you. Actually, I had one more thought that I wanted to share with you, which came up from listening, is that you're talking about the S curve and how you can get the development of opposite curves with one provocative sleep position. We know that in scoliosis, even though when we have a so-called S curve, there will be a primary curve, and that primary curve we can see often by the size of the curve, by the rigidity of the curve, and the associated increased rotation of that section of the spine. So the secondary curve is developing as compensation for the primary curve. So that could explain why, even though you only have one provocative position, which is triggering, say, a thoracic curve, the lumbar curve has to develop or else the person's going to be, tilted off to the side, right? So the body wants to bring the head back up to level so the eyes see the horizon level. It's going to develop a secondary curve. Maybe that has some bearing.
And I agree with that. And also, it's quite possible that they're sleeping in both of the provocative sleep positions throughout the night. What sleep studies showed, I think DeConnick wrote a great study, and he showed that the older we get, the less we move at night, implying that children move an awful lot. So it's quite possible that they sleep in both of these sleep positions, and I can tell you, having a lot of conversations with my patients, many of them sleep in these very same sleep positions.
Okay, I guess we'll wrap it up 9 minutes early. Thank you so much for taking your time. Really appreciate it. This is something that I've been wanting to have happen for a long time, so I feel very satisfied that we finally organized it and we got you to speak to the group. Thanks again, and I really wish you continued success in the development of the pillow company and of the research and getting your paper published. Sounds I had a paper published, actually a couple, and I know the tremendous amount of work that's involved. I wouldn't do it again because it was like it took up like my entire life while I was working on it. So I have a lot of respect for you that you've done this and you've been very successful in it, and I wish you continued success. Thank you, thank you, thank you.
Thank you. I appreciate your all coming, and yeah, it's a very exciting area. And I just want to finish. I've gone on your websites and seen the before and after X-rays, and you guys are doing great work.
Thanks for the vote of confidence.
Yeah, yeah, yeah.
Okay, Heather, you want to wrap it up?
I think you've done a great job.
Okay. All right. Thanks, everybody. And if anybody has any comments or any questions, reach out to Dr. Jarrett. I think he would appreciate to get any feedback that you have for him.
Great.
Okay.
Thanks so much.
Goodbye, everybody.
Bye.